Hi everybody, my name is Sezgin Şahin from Istanbul University Cerrahpaşa. I want to present a compelling DADA2 case with severe malignant hypertension who got the final diagnosis after 2 years. As you know, the diagnosis of DADA2 could be challenging since there are numerous overlapping manifestations with polyarteritis nodosa and other periodic fever syndromes. Early diagnosis is crucial as these patients are generally resistant to classical pan therapy and have high mortality rates. Our objective with this presentation is to provide the struggle of us in diagnosing this DADA2 patient over a period of 2 years, and also to show the treatment failure with various immunosuppressive and anti-hypertensive drugs. This is a chart review of a patient over a period of 2 years. This patient, he was a 9.5-year-old boy, was referred to the pediatric rheumatology clinic with recurrent febrile attacks, the last one being associated with right-sided hemiparesis, exotropia, and ptosis of the right eye, and severe malignant hypertension. The first 2 attacks were at 1-year intervals and characterized by limping secondary to severe myalgia, sudden loss of vision, and increased acute phase reactance. His parents were cousins, and he had a cousin with similar clinical manifestations, as you can see in figure C. His medical history was as follows. At age 7.5, he was admitted to an ophthalmology clinic with sudden loss of vision, fever, and severe myalgia. The low signal intensity in the right retroorbital eye tissue on MRI was reported as suggestive of pseudotumor orbita. There was no evidence of vascular disease or parenchymal disease on MRI of the brain, and also MRI angiography of the brain and eye. Also, there was no evidence of a malignant metastatic disease in high-resolution computed tomography of the lung, and also MRI of the abdomen and spinal cord. Also, the patient's urine catecholamines and also vanillin mandelic acid levels were within normal limits. And also, his bone marrow aspiration yielded nothing. Methylprednisolone was initiated by the ophthalmologist for the pseudotumor orbita for a 1 month of period. After 1 month of period, restoration of vision and normalization of fever were observed. But at age 8.5, the patient again admitted with sudden loss of vision, fever, and myalgia again to the same ophthalmology clinic. His retinal angiography demonstrated central retinal artery occlusion and optic atrophy. He again treated with methylprednisolone and also with hyperbaric oxygen. But this time there was no recovery of vision. And at age 9.5, which was his last admission, the patient was referred to our clinic with fever, widespread myalgia, and this was plus colicky abdominal pain. On physical examination, he was febrile, blood pressure was quite high. There was livedo-reticularis on the lower legs, diffuse muscle tenderness, partial ptosis and exotropia of the right eye, which were suggestive of oculomotor nerve palsy, and there was a decrease in the muscle strength in the right upper and lower limb muscles of the patient, and again deep tendon reflexes on the same side were mildly increased, which all of these were suggestive of left upper motor neuron disease. Investigations revealed mild anemia but very high levels of acute phase reactance. Serum immunoglobulin levels of the patients were within normal limits. With these symptoms and colicky abdominal pain, Mediterranean fever gene analysis was performed, but it was normal. And also there was no response to colchicine therapy. As you know, every patient with recurrent abdominal pain is a candidate for colchicine in our country because familial Mediterranean fever is quite frequent in our country. Electromyography and nerve conduction studies of lower limbs demonstrated asymmetrical axonal polyneuropathy. Brain MRI findings were compatible with hypertensive encephalopathy in the left prefrontal cortex, and also the patient's electroencephalography test was also normal. Conventional cranial angiography was normal. Visceral angiography demonstrated, as you can see in figure A and B, irregularities and stenosis in some of the branches of the inferior mesenteric artery and also the renal interlobar arteries. With the preliminary diagnosis of PAN, the patient received classical PAN therapy, which were corticosteroid plus corticosteroid therapy for 3 days, azathioprine, and also cyclophosphamide. And also the patient received 4 different types of antihypertensive drugs. But the patient showed no response with this classical PAN therapy. Then we established the final diagnosis of ADA2 with ADA2 gene analysis and also with the decreased plasma spot ADA2 enzyme activity. We then started anti-TNF alpha treatment at Etanercept, and following this treatment, all of the manifestations have been disappeared. By the second month of the treatment, antihypertensive medication was no longer required. He has been on the same treatment for 4 years without any attacks. The right-sided hemiparesis and loss of vision have resolved completely. He is able to attend school regularly and he engages in the same physical activities as his peers. As a conclusion, the possibility of ADA2 should be considered in patients with polyarteritis nodosa who have a family history and early onset of clinical manifestations which are predominantly neurological and also which are resistant to conventional PAN therapy. Excellent control of flares could only be achieved by anti-TNF alpha treatment according to our current knowledge. Thank you very much for listening.